Hi everyone, welcome to ResearchMD.com. We're going to continue our interactive case series in the morning report style. So let's hear about the presentation today.
So this is a 75-year-old male, came with the complaints of hematemesis.
Okay, let me stop right there. The thing I don't like, what is the thing I don't like about this? The first sentence he said. How old is the patient?
75 years old.
75-year-old. He said 75-year-old patient came with hematemesis, right? What is wrong with that? Because I need to know what the patient is saying. This is the history of presenting illness. Is the patient is going to come and tell you, I had like hematemesis, or of course not, right? He's going to say like, you have to tell me what is in the patient onwards, so I can make some information. Take that information, come with my differential diagnosis, and that's kind of very important. So, tell me in proper words, what's the presenting complaint?
So the patient complained of vomiting.
Okay, so write that. Okay. So how old is the patient?
75 years old.
75-year-old, and what is the complaint?
The patient complained of vomiting 6 times throughout the day, decreasing in volume and dark in color.
So the complaint is vomiting dark material.
Yes.
Can we say that?
Yes.
Dark material. Vomiting. Okay, that is the complaint, right? The first thing we have to know when is somebody we have to know about, is it like a bleeding coming from gastrointestinal, or blood is coming from the lungs, okay? So those two differences, you have to differentiate, right? So when you talk about, I'm going to go through, let's say like hematemesis. Now I'm just going to use the term hematemesis here, and then I'm going to see like hemotesis, okay? So, what is the number one? When they usually when hemotesis, or hemotesis means your blood is coming from the lung, right? What do they usually present with? The cough, right?
Okay.
In this patient, usually have like nausea and vomiting. That's the most common, like food particles and all that. Okay, next thing is the color. What color usually when the patient come in hemotesis? What color?
Bright red?
Yep, in hemotesis like bright red, okay? And then this is like a dark or black material, usually, dark or black material, okay? Now I look at the pH. What is the pH on this patient? If it is hematemesis, what's the pH is going to be?
Less than
Acidic pH, right?
Acidic.
The pH is going to be acidic. Okay, and then the pH is going to be usually alkaline. So these are the opposite thing. Okay, and then if I put it under a microscope, what do I see in the hematemesis? Usually I would see like food particles. Okay, so this is going to be food particles, and this is going to be neutrophils and macrophages. Usually macrophages and neutrophils. Okay, everybody got that?
Yes.
So just always first remember how do you differentiate between hematemesis and hemotesis, and you got like nausea, vomiting, then there's like cough in the hemotesis, and the dark blood in hematemesis, and then bright red, okay? It's very important to know, in the pH, it's like usually acidic pH because of the stomach, and then this is alkaline, and when you look under microscope, if you need to, there's food particles in the hematemesis, and alveolar macrophages and neutrophils is going to be in the hemotesis, okay? I'm just going to rub this off, and then we'll just go with, tell me the presentation, complete the history of presenting illness.
So the last vomiting episode occurred at 1:30 p.m. on the same day prior to admission.
Yep.
And described dark in color.
Okay, dark material,
Yes.
he was vomiting, okay.
Yeah. And yes, that's it.
That's it.
Yes.
What else do we need to know in this patient? Do we need to know was it like associated with an abdominal pain, right? Why is it
Yes.
important? Studies have shown if somebody have like a GI bleeding and there is no abdominal, which one is will give you the worst prognosis? Let's say somebody with a GI bleeding and an abdominal pain. I'm talking in a general and GI bleeding. If a patient come in and GI bleeding, and one patient said like I'm having abdominal pain, then you got another patient come in, I'm having have GI, vomiting blood, but did not have abdominal pain. Which one is more serious condition? Anybody know?
Abdominal pain.
Nope. All the studies have shown if you don't have any abdominal pain, that's have to be, consequences or complications are much more in those cases. We need to know that. Okay, so only thing now, right now let's talk about, let's talk about a little bit about the differential diagnosis, or like, we had to think about this HEMATEMESIS or upper GI bleeding. Okay, let's do that first. So what is the differential diagnosis going to be here? Okay, let's start with what is the number one cause of upper GI bleeding in the United States? Peptic ulcer disease, okay? So we'll put this peptic ulcer disease, and what is like esophagitis, right?
Yes.
And we can put all that, gastritis. Okay, the next category, I could say maybe like what is some of the Mallory Weiss can cause, right? Mallory Weiss tear. Okay, what else? What are the other causes? Okay, we can say
Esophageal varices.
esophageal varices. Okay, very. You have to be very careful. I would say varices and liver diseases in this category, right?
Okay.
Hepatitis or like chronic liver disease. That's kind of causes like varices, right? And then let's look at the vascular causes. Like, what are the vascular causes of GI bleeding, right? You got blood vessels coming all over the place. So what would be like some of the causes of vascular causes? Right, I think you'll say AV malformation, like one of them. We'll just write AV malformation, okay? AV malformation, and what are the other things? Like some of the other, we have to talk about, Delafoy's lesion. Okay, this is another examination question. Delafoy's lesion. What is Delafoy's lesion? Everybody know? It's one of those, the posterior mucosal artery, very small. It bleed like, very small bleeding. Usually when you do a, endoscopy, you can miss it, but that's a question they can usually ask for the boards or any other type. What is Delafoy's lesion? Usually because gastroenterologists can miss it because small, trickling of the blood could happen. It's a posterior mucosal artery we need to know. Okay, then there's something called GAVE, gastric antrovascular ectasia, right? That can also it's kind of related to the vascular. So usually the common question that can come is the picture. The picture, what does it look like? Because you have the watermelon. When you look at the GI endoscopy picture, you got the watermelon kind of series. You can almost kind of look like a watermelon, okay? And we talk about the GAVE, and there's called Cameron lesion. Anybody know what is Cameron lesion is? Cameron lesion, okay? What is Cameron lesion? Because you got, hernia, hiatal hernia, and then kind of pressing against the esophagus and causing all those kind of symptoms. That is like Cameron lesion, okay? And then you got aortoenteric fistula, okay? Aortic enteric fistula right here. And then what are the other causes we have to worry?
Cancer.
Yeah, let's say malignancy. Let's say that any kind causes of any kind of gastric or esophageal cancer, we need to worry, okay? Esophageal cancer. And the infection causes, like why do we need to worry about infection? Which infection we need to worry can cause GI bleeding?
H. pylori.
H. pylori. Okay, what else? What else? HIV. Okay, that's another question, like the classic board question. And what is the most common cause of upper GI bleeding in an HIV patient? Anybody know?
Most common cause?
Of GI bleeding. You already said if I look at the whole population in the United States, like anywhere in the world, number one cause of upper GI bleeding is, you already said what? Peptic ulcer disease,
Yes.
right? But I'm asking a question, if a patient, they are taking 100 patients with a HIV patient, and then they come up with an upper GI bleeding, what is the most common cause? It's Kaposi sarcoma. Remember that, okay?
Right.
So you got like Kaposi sarcoma, lesion in the esophagus, that causing bleed. So pick that. That's a board question. Examination, they usually ask that. So I will put HIV right here. Okay, so anytime we talk about, we just kind of say, we have to say, with suspecting upper GI bleed, we need to know what is the most emergent situation right here. Remember, we always kind of start on that. The most emergent situation is like, it's a massive bleeding, then you have to call GI and scope or endoscopy and those kind of things. If it is like aortoenteric fistula, also very deadly. So those are the things I'm just going to be, be very careful. Aortic enteric fistula, remember that, okay? That's another emergency right here. So We'll go through our differential, we talk about the most common cause of peptic ulcer disease, right? And then esophageal gastritis, you got malarious and varices, liver tissue, that's like another cause of bleeding also. Then vascular malformation, dilophoylation, gastric vascular ectasia, and then we remember the what?
Aortic fistula.
No, what is the classic finding in the GAVE?
Watermelon.
Watermelon lesions. Okay, you got Cameron lesion, always associated with the what? Hiatal hernia. Okay, remember these are all questions like, examination kind of question. And then you got the aortic enteric fistula, which is an emergency, which we'll talk about it later. And then we got, malignancy, any kind of like gastric malignancy, esophageal malignancy we need to know. And then infectious causes, you already said like H. pylori have contribution to all of this. And then HIV causes we need to know. Okay, now let's go to the past medical history. What is the past medical history in this patient?
So the past medical history is positive for COPD.
COPD, okay.
Diabetes mellitus.
Diabetes, okay.
Malignant neoplasm of lower third of esophagus.
So esophageal cancer.
Yes.
Okay.
Good.
All right. So why is it we worried about now? Now our differential diagnosis is going to change. This patient has esophageal cancer. That can also like kind of concept we talk about in this malignancy kind of picture. It could come up here. One of the differential diagnoses we need to worry. Okay. What else? And then you got allergies. Anything?
Yes, he's allergic to amoxicillin clavulinate.
Okay, amoxiclavulinic acid. What else?
Doxycycline.
Doxycycline. Okay. All right. And then what is the other thing?
Past surgical history.
Okay, past surgical history.
Okay. He has undergone gastric bypass surgery.
Gastric bypass surgery. Why is that important? Can it cause bleeding? Of course. When some people have like gastric bypass, there's like around like 6 to 7% of the people can have like ulcers is very common in these people. So you have to know that. Okay. So you got gastric bypass. What other surgical history I should know in a patient? What else causes like GI bleeding? Remember when you talk about aortoenteric fistula, right? If somebody have like abdominal aortic aneurysm, they put that prosthetic material there and then can rub against esophagus and cause the aortoenteric fistula. So it's very important to know that. Okay? So just kind of ask you like, abdominal aortic aneurysm. Okay, what else? You have to know medications, right?
Right.
Tell me what medications the patient.
So the patient is on aspirin.
Aspirin.
Right.
Is that important to us?
Yes.
Of course, can
Yes.
cause bleeding, right?
Yes.
Okay,
Yes.
what else is it? What else?
Dexamethasone.
Dexamethasone.
Right.
Why should we worry about steroid in GI bleeding? Why should we? Is it important? Like if somebody is on a steroid, they can have like 40% increased chance of upper GI bleeding.
Okay.
Okay, so it's
Okay.
very common. So you just have to be okay. What else the patient is on?
So he's on atorvastatin.
Okay, statin.
Yes. Lamotrigine.
Okay, not much important to us. Okay, and then let's talk about the family history is important.
Yes.
Yes.
Okay, why? Any kind of malignancy, I think. Any significant family history in this patient?
No, not really at all.
Okay, all right. And then we talk about what? Social history, right?
Yes.
Tell me about social history.
So he currently does not smoke.
Okay.
He's a former smoker.
Negative smoker.
Yeah.
Okay, what about alcohol?
No, he doesn't take alcohol or any illicit drugs.
Okay, no alcohol history. Any illicit drug history or
No.
anything we need to know, right? We talk about, the sexual history is important to know.
Yes.
All right, we talk about HIV
HIV,
and all that,
right.
post-sarcoma condition.
Right.
So it's very important to talk about it. And psychiatric history, why is it, this patient have any psychiatric history?
Yes, Dr. Cheriyath.
Okay, why is it important psychiatric history? Like one reason is like, a lot of patients on SSRI. SSRI is another cause of like GI bleeding, okay? So it's also important in the medication they take. Other than that, I don't know how much.
Eating disorders.
Eating disorder, like,
If they are purposefully vomiting and that can cause malarious.
Yeah, very good thought, excellent thought.
Okay.
Like, where like an eating disorder or something, they purposely that can malarious. Very good thought, actually. Okay, so think about like any eating disorder.
He's positive for bipolar disorder, major depressive disorder.
Okay, so the medication history is not important, releasing, very good. Okay, now talk about the vital signs, right?
Right.
Okay, tell me the vital signs.
The vital signs, his blood pressure is 122/60.
122/60, okay?
Okay. 98 Fahrenheit. The
98.
temperature is,
Okay,
pulse is 100.
okay,
Respiration 18. Saturation 95%.
95%. Okay. What do you think about this vital sign? Am I happy about this vital signs? You are? I'm not happy. Why is that? Why am I like, I'm
Widening
not...
pulse pressure.
Huh?
Widening pulse pressure.
Why didn't, maybe, yeah, why did prosperity there? But what else I'm not, why isn't like, I mean, I'm happy that somebody gave me this blood pressure. What's my next step? What should I check for in this patient? Anytime somebody with the GI bleeding, doesn't matter upper or lower GI bleeding, what should I ask? The nurse or somebody gave me, or like, you know, your doctor give me the vital signs. What's my next question is going to be? Give me the orthostatic vital signs. Okay? So check the orthostatic right here. Why is that? Let's say if this patient is like is a positive orthostatic, that means they lost 40% of the volume in the body. Okay, that means like, I mean, because you cannot just go by hemoglobin in this patient, right? So always check the orthostatic in this patient. You know how to check orthostatic? Somebody tells me what is it? Like you look at the systolic blood pressure less than 20, diastolic less than 10, heart rate greater than 20. Okay, remember always, it's just if you cannot, usually I do by myself. I see a patient, I ask him to sit up and stand up and then measure, like, wait 2.5 minutes and do that. So if it is orthostatic positive, then do that. Okay, and what is the next step? You have to examine the patient, right? Now, we have to be very specific. We don't have the time of the trying to go from one system to the other system. Let's look at the general examination. Like, what are we actually looking for?
Pallor, dehydration.
Okay, let's start with the eye, right? There's like a pallor, very good thought. Is there any pallor in this patient?
No.
Is there any pallor?
No.
So negative pallor, we need to know that. What else we need to know? Do we need to examine the mouth in upper GI bleeding? Of course.
Yes.
Sometimes you can have this bleeding or anything kind of thing. Sometimes it's polyps. I didn't, like a fused Jagger polyp can have like, the lesions in the mouth. So that's another board question kind of thing. And then always kind of make sure there's no bleeding or something kind of blood is kind of trickling into the stomach or the other areas, right? What else? What are the general examination, the skin examination? What are the other things we need to be
Abdominal
important?
distension.
No, we didn't come to abdominal, like skin examination. Always look for what? Signs of liver disease. Okay, can the liver disease is the varices is a big one of the differential diagnosis. So first thing I do look at the liver signs. So start from the eye here. Tell me like what are we looking for?
Jaundice.
Jaundice in the eye. What the bilirubin has to be greater than 3 for to have jaundice information, right? What else?
Spider angioma.
Spider.
Okay, spider angioma. Okay, what else? What about the hand? What am I looking for in the hand? Palmar erythema. Okay, maybe they're like asterixis. They're like that's kind of like a later kind of stage. This patient didn't have it. Look for palmar erythema, gynecomastia, right? And then ascites, and then testicular atrophy. Those are the most common kind of findings. So I remember to make sure I check all that. Okay, so let's talk about and then cardiovascular system examination. Why is in cardiovascular system is important to our patient? Why? What are we looking for? Okay.
Aneurysms.
Huh? Yeah, like an abdominal aneurysm, definitely, right? Abdominal aortic aneurysm, we just have to be already talk about, like you can rub against it, but the findings may not be like and all that. Which valvular disease associated with the GI bleeding? Which we did not put in one of the differential diagnoses. Aortic stenosis. Okay, very common. Aortic stenosis patient, the GI bleeding is very common because they can have like AV malformation. So we just have to, let's put it in the vascular aortic stenosis also. Okay, so just remember that. Okay, and that's what and look for a murmur, aortic stenosis murmur, classic systolic murmur, going into carotid. Everybody know that, right? So we looked at it, and then we come to the GI abdominal examination. What are we looking for abdominal examination? I think is there any pulsating lesion, right? You already talk about this aortoenteric fistula, those kind of thing. First thing I look at it. Then I look at what else? Ascites, right? How do I look at the ascites? I look at the position of what? Umbilicus, right?
Umbilicus.
And all those kind of things kind of tell me. I look for any masses kind of like that also kind of tell the umbilicus position is going to be checked, right? I need to know the vowel sounds, this kind of thing. Rectal examination is important, of course it is, right? I mean, they can have like a melena, those kind of thing. Always when you do rectal examination, do systematic. I see the people make the mistake already. Or rectal examination, hemoculposity. Am I happy with that? Not really, okay? When you present a rectal examination, always you look from outside. There's like anal fistula or anything kind of hemorrhoid, those kind of thing. Okay. Then you just look at the tone, right? Tone of the, and then you look at the, vault and see what's inside the vault. And then after finally you come to and say like, the color of the stool, and then we talk about, the smell, those kind of things kind of important to us. So all of this kind of checked. So do you have anything positive in this patient?
Yes, the abdominal, there's a palpable mass.
There's a palpable mass?
Yes, in the left upper epigastric region.
Oh, left upper epigastric palpable. Left upper epigastric region,
Yes.
palpable mass.
Yes.
Okay. All right. What else? Now we just go into the investigation or lab. What labs are important to us? Tell me which labs are important. CBC is important to us?
Yes.
Of course. So tell me the CBC.
WBC is 3.3.
3.3. Okay.
Hemoglobin 9.8.
9.8. Why is the hemoglobin is important in the management?
To know
When
how
do
to
we
transfuse.
transfuse? Yeah, which
Below
le-
7.
Below
Less than
7.
7.
Always remember the magic number. Which other situation you have to transfuse? Like, if somebody has CHF and those kind of
Yes.
thing, I would kind of keep it like between 8 and 9 and all
Right.
that, okay? And then, platelet's important. What is the platelet?
188.
188. Why is it important? Of course, you can have like
Bleeding.
and all
Bleeding.
that, right?
Yeah.
Those kind of thing. Okay, and what else we need to know up here?
Okay, so. His
Sodium.
RD
Okay, sodium.
Yeah.
What is the sodium in this patient? Normal?
Is 140 normal.
140, okay. Potassium?
3.8.
3.8, okay, and then other one,
Bicarbonate 29.
29.
Yes, chlorine.
All right, always kind of think about abdominal pain and abdominal kind of, any kind of abdominal stuff, metabolic acidosis can cause usually more like in the lower GI bleeding kind of thing, not that much, but lactic acid or those kind of ischemia. That's what I'm saying.
Yes.
Some kind of blood compromise there, so that is kind of important to me. BUN and creatinine?
Yes, BUN is 7.
Uh-huh.
Creatinine is 0.85.
0.85. What does that tell us? Why do we need to know the BUN and creatinine in upper
Dehydration.
GI bleeding? Huh?
Dehydration.
Dehydration, okay. Dehydration also kind of like, hyponatremia. Why is it kind of related to GI bleeding?
Hemolysis.
BUN creatinine ratio, okay? If the BUN creatinine ratio is like greater than 30 to 1, okay, greater than 30, your diagnosis of upper GI bleeding is extremely high.
Okay.
Remember, you got it? Always, when you think about upper GI bleeding, in this patient, the ratio is less. I'm not kind of like, not kind of saying all that. Why is it BUN goes up? Because you got this blood product kind of break down to protein, and then it's kind of like usually the end product to become urea. So
Right.
BUN kind of goes up. Okay?
Okay.
Blood urea nitrogen goes up right there.
Glucose is
What-
175.
Yeah, okay, but again, the glucose we just need to be. What else do we need to order in this patient? What are the lab tests would you order?
INR
INR, PT-INR, right?
Yes.
What is the INR in this patient?
1.17.
1.17, okay? Let's this patient is on Coumadin and the INR is like 2.8. Then you have to scope the patient. What would you do? Would you scope the patient? You would say like reverse the anticoagulation, or what would you do? Is anybody? The magic number is 3, okay? If the INR is like, as long as it doesn't go above 3, GI people should go and scope the patient. That's the main thing you have to do, okay? But so remember, you need to know the INR. What else we need to know? Maybe lactic acid is not a bad idea. I think, all this patient, ischemia, those kind of things. What else we need to know? Liver function test we need to know?
Yes.
Yes.
Okay, are they normal?
Yes, they are normal.
Okay, but is that much important? Is a chronic liver disease, liver function test is not that important. Okay, what are the two lab tests we can say the difference between this patient and chronic liver disease? Which one? Which tell us synthetic function of the liver. One is already INR, albumin. Okay, we need to know. Because those are the things synthetic function of the liver. If the albumin is low and INR is high, then I saw liver, I'm just kind of worried a little bit what's going on, okay? Got it. Okay, what else? Anything else we missed? Nothing else?
No.
You didn't check anything else? Okay, I'll come back to that. Okay, what investigation this patient have?
So the patient has undergone CT chest abdomen with contrast.
Okay, your doctor already did an CT and abdomen,
Right.
which I don't usually that's not the initial kind of thing. You have to scope and all that. But this patient have what? Malignancy.
Right.
Maybe that's the reason they did. So what did the patient already has esophageal malignancy,
Yes.
and then there's some palpable mass also.
Yes.
So what is the finding in the CT
The impression
test?
was wall thickening at mid to distal esophagus.
Wall thickening.
Yes.
Esophagus. Okay, we're just
Yes.
gonna write that.
Correlates with neoplastic process.
Okay, so that is, we just gotta talk about, right? So this is what, so far we know, we got a 75-year-old upper GI bleeding, right? And then we got like a malignant lesion that could cause it. So what is my number one diagnosis? What do I write? Upper GI bleeding.
Right.
Upper GI
GI
bleeding,
bleeding.
okay?
Okay.
Esophageal malignancy, right? Okay, and then I write the hemoglobin, right? What is hemoglobin?
It's
9.8.
9.8.
9.8. So no need for like urgent transfusion in this patient. What are the the basic step what we need to do? Like in the first thing, we gave the diagnosis. What is always the thing I talk about it, right? Right?
Yeah.
So what is the number one thing I just have to do? Like when I come with the diagnosis, I always bring a little bit of statistics, do a risk assessment model or risk assessment score. Remember, when somebody presenting to me with the chest pain, I need to know the heart score or TIMI risk score, okay? When somebody presenting me a pulmonary embolism, I need to know what's the well score. So in this patient, what kind of scoring system to do that? To measure like the seriousness of the patient. There's something called a Glasgow Blatchford score, okay? That's what you need to calculate, okay? Glasgow Blatchford score. I think Glasgow Blatchford score. Okay, so we need to calculate that. Somebody calculated the Glasgow Blatchford score, like what are the components? You got BUN and nitrogen if it is less than 18. So this patient have less than 18,
Yes.
right? And the hemoglobin is like the next component. So we just got a BUN. What is the number for BUN? BUN is less than 18. Okay, BUN less than 18. And let's say next thing is what? The hemoglobin. Hemoglobin is like less than, there's like anemia, like less than 13, okay? And what else? And the hemoglobin is like 13. Or, okay, I'm sorry, like when you say about I always kind of get this, hemoglobin has to be, hold on a second. Okay, hemoglobin, it just have to be like 13 is the number. If it is less than 13, right? We just have to worry about it, right? And then, okay, and the next one is this systolic blood pressure in there. Like a systolic blood pressure, what is the magic number? It has to be greater than 110, right? Okay, and then what else? We have like pulse. What is the pulse? Pulse has to be like less than 100 per pulse, less than 100, right? And then, what is the other thing? Absence of, what are the other things? Like absence of syncope, CHF, liver disease, that's sort of the main component of the any kind of cardiac failure, liver disease, absence, okay? So let's go over the Glasgow Blatchford score one more time. So like, BUN is less than 18 and the hemoglobin is the magic number is, it has to be like, if it is greater than 13 and then SBP like greater than 110 and the pulse is like less than 100 and absence of all these things, and if at least you get a score of 1, the mortality rate is high, and then you need to keep the patient in the hospital. Okay, so with this patient I have what are the scores? What is the scoring in this patient?
Okay, so it's,
Somebody calculate the Glasgow Blatchford score.
okay.
Okay, what is it? Is it 1?
I think it.
Yes, BUN is less than a hemoglobin.
So hemoglobin is 9.
Hemoglobin, so that's 1, right?
Right.
Okay, and then you got SBP, pulse is greater than less than 100. I think
Yes.
pulse is kind of 92. But this patient have no history of syncope, CHF, and all those
Right.
kind of things. So we just say like a 1, right?
Right.
Is that right? So that is like high risk. Am I correct? Okay, so just calculate the Glasgow Blatchford score, and based on that, I decide to keep the patient in the hospital or discharge the patient. Okay, what's the next thing we have to do? Next thing is like we need to make sure like 2 large bore IV tubing, right? Make sure 2 large bore IV tubing. IV the patient have. What else? I make sure like the blood is ready. Okay, type and cross. Okay, I don't care. Even if the hemoglobin say like 18, 20 and all that, I always write an order, type and cross, because you never know. You have to look in advance like what's going to happen and all that, okay? And the type and cross, and then, definitely we need like, okay. All right. NG tube, that's the other question. Do you put an NG tube in this patient?
No.
No, don't put an NG tube. The studies have shown that when somebody have like an NG tube, right? What happens is like an outcome is not different. Only thing they found out, GI doctor will come and scope the patient faster. GI doctors will be making more money. They can ride their BMW and all that. So NG tube does not affect the mortality, right? And then we call the GI consult. Of course, GI call. You need to do anything right away. GI consult, endoscopy we have to do. What is called EGD? Okay, why is EGD important to us? Right? What are we looking for? We said like peptic ulcer disease, like number one cause, and we see like malignant, anything kind of thing. We need to know it's a dilaphoisolation and all that. Okay. One other question we need to know, when you do like a upper endoscopy, we need to know this ulcer. Why is it also characteristic of the ulcer is important to us?
We can tell the source of infection. Like
No, this not the source. When you have an ulcer, right? If you have like which one have the highest incidence of like bleeding or rebleeding? Okay. If there is an ulcer and there's a visible vessel next to it, the risk of bleeding is like extremely high. Rebleeding. That's why they have to cauterize. Okay. Let's say if you did endoscopy and the patient have like a visible blood vessel around the ulcer, I know the risk is extremely high. So what am I going to do? Am I going to discharge the patient out of the hospital right away? No, I rather keep him on. I will just put him on like protonics and those kind of things we need to do. Remember, if it is a clean ulcer, the chances of bleeding is like less than 5%. Okay, so remember, if there's an ulcer and there's a blood vessel around it, chance of bleeding is like extremely high. Even if you cauterize, they can bleed. Keep them in the hospital and watch him before you may discharge. Of course, and what else is the drug you have to give? IV protonics, right?
Yes.
IV protonics, we will start. Okay, so in summarize, you put the diagnosis, what do you think, what is the causing, and calculate the Glasgow Blatchford score, risk assessment number thing, and then you talk about the management, start the patient on IV protonics, make sure the blood is ready, make sure you check for orthostatic hypotension, make sure you call GI, and even if your GI calls in, just ask him, hey, is there an ulcer? What are the characteristics of the ulcer? Okay, so any other questions about this case? Okay. Thank you so much for watching. If you have any comments or any other way we should have managed this case, please put it under the comments. It's a discussion and we can kind of talk about it and everybody can learn teaching each other. Thank you so much for watching. We'll be back.